Good morning. I'm Eric, and I'm going to talk to you about HLH today, or Hemophagocytic Lymphohistiocytosis. So I'd first like to thank HOPA for having us, and then all of you for choosing to come to our presentations, as I know you have a lot of choices this morning. So basically, I'm going to talk about what Dr. Bowie talked about, but instead of medications causing the CRS, it's a genetic mutation or some kind of immunologic trigger. Objectives for today are to recognize the diagnostic criteria for HLH, identify current evidence-based treatment strategies for HLH with somewhat more focus on adults, and describe areas of future research for treatment of HLH. So first, I wanted to find out how your institution currently treats HLH. So A, using the HLH 1994 protocol, B, the 2004 protocol, other, or we haven't treated HLH, or I'm not sure. And then just a reminder, the login code is HOPA4 if it works. Yeah, so it doesn't seem to be working. So we're going to go old school and raise our hands. So for A, the 1994 protocol, I would raise that for KU as well. B, the 2004 protocol. Other, and then we're not sure since it's pretty rare. Okay, so we have a wide distribution kind of all over the place. So for epidemiology, it's a pretty rare disease. It's about 1 in 50,000 live-born children, and the first reports of it were in the 1950s by Scottish pediatricians. There's an estimated 1.2 cases per 1 million individuals per year, and the incidence in adults is widely unknown. About 80% of cases are in children less than 1 year old, but at KU we treat mainly adults and on my service. So I'm going to focus somewhat on adults, but a lot of the protocols we talk about today are based on pediatric protocols, so there should be a little bit of something for everyone in this presentation. Generally, it's a very difficult disease to diagnose and treat because it is so rare and there's a lack of consensus guidelines, and then the majority of resources that we have are focused on pediatric patients. So when we talk about survival, in the early 1980s, the 1-year overall survival was reported to be 5%, so very poor. And most of these deaths were due to the cytokine release, which resulted in infections or organ failure and CNS dysfunction. Over 20 years or so, that greatly improved to 54% at 5 years, and this is widely due to many things. Number one being the inclusion of etoposide and the development of some of these new protocols in 1994, as well as better supportive care, better use of transplant, and then better diagnostic guidelines as well. So to explain the pathophysiology of HLH, it's really a syndrome of immune dysfunction. So you have some kind of predisposing immunodeficiency, which increases the immune activation, and you get the cytokine release. It also results in decreased cytotoxicity of natural killer cells, reduced apoptosis, and then increased cytokine release. There's an accumulation of macrophages that cause phagocytosis of erythrocytes, platelets, and leukocytes in the bone marrow, and also other tissues. Other tissues can include the spleen, the lymph nodes, the liver, and also the CSF. So there's a lot of information on this slide, but basically you get these hyperactive macrophages that destroy other cell lines. There are two types of known HLH, familial and secondary. Familial HLH is also known as genetic or congenital or primary. It's an autosomal recessive disorder, and so because of that, a lot of times people actually don't have a family history of it, which is important to keep in mind when we talk about the 1994 protocol. It occurs mainly in infants and children. Infections can also trigger it too, and it's prone to recurrences, and we do know that with familial HLH, transplant is needed for cure. For secondary HLH, it's also known as acquired or reactive, and it can occur at any age, but the majority of adult cases that we see are secondary HLH. The triggers that are described in the literature are infections such as EBV, which is the most common, rheumatologic disorders, malignancies, mainly of T cell or natural killer cell lineage, metabolic disorders, and then there are also some medications. So methotrexate, etanercept. There's also one case report, pegfilgrastim, causing it, which I'll talk about a little bit later. And then with secondary HLH, it actually can spontaneously resolve. So we understand familial very well. It's a genetic mutation that causes it, whereas secondary HLH, how this trigger causes it is not quite as well understood. A little bit more about secondary HLH. So EBV is one of the most common infections. Mayo actually did a review of their 62 adult patients, and 50% of the infections were due to EBV. They noted that survival is improved if etoposide was included, and Rituxan can also be beneficial, and that these patients can require transplant. So for secondary HLH, transplant is generally not needed unless it's refractory or it recurs, which we'll talk more about. And then for malignancy, we really want to control that cytokine storm first, and then we can treat the specific malignancy. So what are some of the signs and symptoms of HLH? They're very wide and variable and pretty nonspecific. The most common ones are bolded for you. So fever, this can be very high fevers, up to 102, 103 degrees that last for days to weeks. Hepatosplenomegaly, hepatitis, which can be a direct lymphocyte infiltration of the liver, and then having this sign and symptom up front can predispose them to VOD with transplant. Jaundice, hypertriglyceridemia, lymphadenopathy, skin abnormalities, which can be rash or petechiae, edema, pulmonary dysfunction. Once you start treatment, if pulmonary dysfunction actually declines, then that can actually be a poor indicator of disease control. DIC, which occurs in up to 95% of patients. Cytopenias are a common manifestation, but it's also a late manifestation. And so generally about 80% of the patients that present already have anemia and thrombocytopenia. And then neurologic dysfunction, which is a poor prognostic indicator. So they can present with seizures or cranial nerve palsies, and this is about 1/3 of patients. And the protocols actually recommend that everyone have a LP and a brain MRI, even if they are asymptomatic. So the diagnosis of HLH is challenging due to the rarity of the disease and this nonspecific presentation. There's also a longer time period with some of the testing to come back, so that can complicate things. And then, interestingly, not all patients exhibit hemophagocytosis. It can actually be one of the later signs, and so you should not delay treatment or diagnosis just because they don't have this. It's actually one of the least important indicators. So if you suspect HLH, you should treat it. So here are some of the workups, and I've divided this into diagnostic workup, genetic, which is a lot of the mutational testing, supporting evidence, and then screening for some of the triggers. So a couple things that I wanted to highlight were in the diagnostic. So for ferritin, which he actually mentioned in his presentation, it being greater than 10,000 grams per deciliter is pretty specific and sensitive for HLH. And then soluble CD25, which you'll sometimes hear referred to as IL-2. It's generally a send-out lab that takes some time to come back, but is one of the most specific trackers for the disease, if you will, since it's a reflection of T-cell activation. So it's really important to try to use this lab if you can. And then soluble CD163 is also another key into the immune system activation that can be marked as well. So diagnostic guidelines for HLH. So actually the first set of guidelines was published in 1991, prior to the 1994 protocol starting. At that time, the difference between those guidelines and what's used for HLH 2004 is that we didn't have the molecular diagnostic criteria. So that's something that was added in these 2004 guidelines, as well as ferritin and elevated soluble CD25. So for diagnosis of HLH, you either have to have one from the molecular diagnostic column on the left or 5 of the 8 criteria on the right. One thing I do want to point out that we said earlier that if you have a suspicion of HLH that you would treat. So even if they don't have 5 of the 8 yet, they probably will at some point. So if you suspect it, you should still treat it. For the molecular diagnosis, PRF1, which is bolded there for you, it's one of the most common mutations occurring in 20 to 40% of patients. And remember that our pediatric patients mainly have this familial subtype or this genetic subtype. So that's going to be a large majority of your peds patients, whereas adults are really going to follow more of the clinical criteria for diagnosis because most of them are of the secondary HLH subtype. So the criteria for secondary, or the clinical criteria, would be fever, splenomegaly, cytopenias in 2 out of 3 lineages, high triglycerides or low fibrinogen, hemophagocytosis, low or absent natural killer cell activity, high ferritin, or elevated IL-2. So a question that's been raised in a lot of the recent reviews is, are the HLH 2004 diagnostic guidelines sufficient for adults? Because they were developed with pediatrics in mind for those protocols. The answer is probably not. We know that genetic mutations are very low in our adult population, and it's inversely correlated with age. So there's been a couple of different proposals for new criteria for secondary HLH, and these include the H-score, which is free and available online, and it uses 9 different criteria. And there's also the Delphi study, which really just pulled some of the leading leaders in HLH and wanted to find out what they thought was important for secondary HLH diagnosis. So moving on to treatment, we know that if we don't treat these patients, their survival is extremely poor. And prior to the 1980s, it was extremely poor prognosis until we started using etoposide. They found that etoposide could induce remissions, but it couldn't provide a cure. So they developed the first prospective protocol, which is the Histiocyte Society of 1994, HLH 94. Some key points of this treatment was to begin quickly because it was essential to survival regardless of whether they had cytopenias, infections, or organ dysfunction, and then start on the treatment of strong suspicion. They also would send HLH typing up front in case they needed a transplant, and that was indicated for familial HLH, patients with CNS disease, or if they had any type of disease reactivation. So this is a general treatment overview. So the induction period, which we'll dig into a little more, is 8 weeks. And then if you had familial HLH or CNS dysfunction, you would need a transplant. And so you would do your induction and then continue on to continuation therapy until you could get to transplant. On average, this took about 6 months in the 1994 protocol. If you had persistent secondary HLH, then you would do the continuation therapy until transplant. But if after 8 weeks of the induction, if your secondary HLH resolved, then you could actually stop therapy and just monitor. One thing that did change between the 1994 and the 2000 protocol, or 2004, excuse me, was what to do if they reactivated their secondary HLH. So in the 94 protocol, they used to go just to continuation, which I'll show you, but with the 2004 protocol, they actually recommended going back to induction, which is a more aggressive therapy. So with the 94 protocol, goals were to suppress this life-threatening inflammation or cytokine release, reduce the number and degree of permanent complications. It was designed primarily for familial HLH, but it was open to all patients. But remember, at this time, we did not have the molecular testing, so familial was largely based on whether or not they had a family history, and since it was an autosomal recessive disease, they may not have. Cure disease by transplant if indicated. And so for this protocol, they use a combination of etoposide, steroids, and intrathecal methotrexate. And I'll go over that on the next slide here. So just to kind of orient you, on the left-hand side, you have your drugs. The doses of the drugs are at the bottom. And then in the middle section there, you kind of have your chart and your schedule of dosing, which is weeks 1 through 52. So starting at the top, the dexamethasone, maybe IV or PO up front. IV is preferred at initiation, and it's dosed milligrams per meter squared. So you have pretty high doses beginning at the up front of therapy, and then once you get to the continuation phase at week 9, then you do dexamethasone pulses. For the etoposide, it was 150 milligrams per meter squared, and you start off twice weekly, go to weekly, and then with continuation, it spaces out a little more. Cyclosporin for the 94 protocol was started with the continuation therapy. In the 2004 protocol, they actually moved it forward to start with the initial therapy and the induction phase. And then IT therapy, which this dose is adult dosing, the 12 milligrams, to start as soon as safely possible. So they said week 3, but it can actually start earlier or later. And then if they actually have CSF disease, then you would continue until not only their CSF is clear, but also that their symptoms resolve. So the long-term results of this 94 protocol is there were 249 patients, and the maximum age for this protocol is 15 years old. There was a 78% success rate, which means they were either alive at follow-up or they were able to get to a transplant. The median follow-up of 6.2 years, the 5-year overall survival was actually 54%, and this improved to 66% following a transplant. For familial, the 5-year overall survival was 50%, and no patients with verified familial HLH survived without transplant. For CNS disease, their 5-year overall survival was actually lower, and this was 40% versus 67% in patients with neurologic symptoms. And then one point I wanted to point out from this protocol that I thought was interesting is that 10 of 15 patients with neurologic symptoms actually improved without IT therapy, which raised the question of how important is the IT therapy, and we really still don't know the answer. Major toxicities from the trial were neutropenia as well as neurologic complications. But the biggest takeaway from this is that actually 20 to 25% of patients actually died before they could get through induction into a transplant. And 94% of these patients still had active disease. So we knew that although these results were better than the 1980s, it still wasn't where we needed it to be. And so that's when the 2004 protocol was developed. So major changes from the 1994 protocol were that they included patients up to 18 years old, but they also were willing to do a sub-analysis of patients if they were older. They would just be studied separately. They moved cyclosporin to the beginning of induction to increase the intensity of the regimen without causing more myelosuppression. They also recommended that you could omit the first 2 doses of etoposide if patients had a low ANC and a hypocellular marrow. They added hydrocortisone to the intrathecals, and then they changed how to manage reactivation. So instead of going to continuation, you would go back to induction. So this study was completed in December, and I contacted the primary investigator, and they don't have any results yet, but they're expecting some maybe later this year in the summer or fall. So a couple of key pharmacy points that I wanted to point out from the studies is there are some dose reductions that are recommended. So you should dose reduce your etoposide for renal dysfunction, and then you would also reduce it if you have renal and hepatic dysfunction, meaning an elevated direct bili. So interestingly, there is no dose recommendations for isolated hyperbilirubinemia. And these are actually my old slides. I don't think it got updated, but I also included a caveat here that keeping in mind that these protocols were developed for pediatric patients. So our adult patients are not as robust, and these dose reductions might not be as aggressive as they need to be. So as an example, we just had a patient a couple months ago who presented with hyperbilirubinemia, but no kidney dysfunction. And so her direct bili was 7, and we did not feel comfortable doing full dose based on that. So I contacted the PI and then one of the How I Treat authors to see what they would do for an adult patient. And what we ended up doing was a 50% reduction for that patient, and then we escalated the dose as she tolerated it. So just keep that in mind for your adult patients. So I wanted to include a couple of things. So when would we expect a response? So we would expect a response at 2 weeks, whether that be a partial or it could be a CR. It's probably unlikely, but you should have resolution of the disease at 8 weeks, and I've included the criteria here for both of those. And so if you're not seeing a response at 2 weeks, you would want to start thinking about salvage or changing to something different. I'm not going to go through all of these for the sake of time, but they're there for you. So some alternative treatment methods up front if you have maybe an adult patient you don't think can tolerate this therapy. We have used corticosteroids with ATG, which really has high response rates, but actually has higher relapse rates than what's reported in the HLH protocols, and there's no head-to-head comparisons. Also, in many of the reviews and case reports, they've used a CHOP-like regimen for adults without the anthracycline if they don't think they can tolerate the high doses of etoposide. This slide is very busy, but I wanted to cover transplant a little bit for HLH. So there's been several different types of donors that have been utilized. There's been matched SIBs, haplos, mismatch. There's even some cord transplant reports. So I included a nice review from 1995 to 2000 and the outcomes of those. Historically, they've used a myeloablative preparative regimen with etoposide, busulfan, and cyclophosphamide, but there is more data coming out for reduced intensity, and actually there's currently an open trial for that. There was a really nice review at ASBMT for transplant and specifically HLH, so if you wanted to check that out. And then one thing I did want to point out is that active disease actually doesn't mean you can't take someone to transplant. They just can't be in the cytokine storm. And so a lot of times alemtuzumab is used as a bridge to transplant. So what do we do for recurrent and refractory disease? So for recurrent disease, we would re-escalate the dexamethasone and etoposide starting at week 2 of that induction period and then move on to continuation while awaiting transplant. So this could be a secondary HLH patient that initially responded, but once you recur, then you would be a candidate for transplant. For refractory disease, we should see at least a partial response in 2 to 3 weeks. So if we haven't seen that, then you need to start thinking about salvage therapy and transplant. So here are a couple listed salvage therapies for you. So these weren't addressed in either of the 2 protocols, but options that have been reported in small case reports and case reviews are steroids with progressive tapering along with ATG, infliximab, daclizumab, alemtuzumab, as I mentioned, anakinra, vincristine, toci has been reported as well, and there's a couple of other agents in study I'll talk about too. This is a nice slide I included for monitoring. I really like to use this a lot. It just gives you some idea of how often you should be checking all of the different labs, so that's pretty useful. And then to mention some supportive care aspects, so if patients have infections, you should use IVIG. And remember with our infections that doesn't differentiate between the 2 types. So familial can still have infections, secondary can still have infections. And then with the cyclosporin, we want to do strict management of hypertension as these patients are at risk of PRES. And then with our high doses of steroids, we want to give infection prophylaxis with PJP prophylaxis and fungal weeks 1 through 9, as well as stress ulcer prophylaxis with that. These patients should have broad-spectrum antibiotics for fevers and full ID workup, as they can have concomitant infections. Then they're also at a high risk of spontaneous bleeding, so no heparin, keep their platelets above 50,000, use cryo, FFP if you need to. And then this is actually kind of controversial on my service of whether or not to use GCSF. Generally, we have tried to avoid it because there is that case report with pegfilgrastim actually inducing an HLH. And plus you're giving chemotherapy so frequently that we're really not sure if that's safe. So generally we have tried to avoid the GCSF. So a couple areas of research. So we have HLH 2004, which those results are pending. We also have the HIT trial, which was a hybrid immunotherapy trial that used etoposide, steroids, ATG, and ITs, and it's completed with results pending. There's also LDEP for EBV-associated HLH, so it includes pegospardase. There's a couple of alemtuzumab trials. There's also a monoclonal antibody that got breakthrough designation. So those results are pending for that. And there's some TOSI trials, and then the protocol I mentioned for reduced intensity condition is CTN 1204. So in summary, we know that the addition of etoposide greatly improved responses, but not cure rates. The results of the 2004 protocol are pending, but it's often used in practice due to the number of early relapses identified in the 94 protocol. Although I don't think either, personally, is incorrect to use. And in fact, if you read some of the How I Treat articles, you'll actually get differing opinions. So generally, my own thought process is to try to use the 2004 if we can. But in our adults who might have renal dysfunction up front, it's still okay to follow the 94 protocol and add the cyclosporin later if needed. And in fact, we know that many of the secondary cases may not require as aggressive therapy since they generally respond pretty well. We just aren't currently sure what the optimum therapy is. Transplant remains the only curative option. It's performed for familial HLH as well as those with CNS disease and then relapse refractory secondary HLH. Early identification of poor responders is needed and crucial, so remember that 2-week time frame. If you're not having a good responder, you need to switch therapies. And then further investigation of effective salvage options is needed, as well as more information about how to treat adults. So we have a case report here for you. So we have a 30-year-old female admitted for cellulitis and high fevers. She has a known T-cell lymphoma and an ankylosing spondylitis, so she also has, on top of that, an autoimmune disease. Infectious disease workup revealed negative blood and urine cultures, but a wound culture positive for MRSA. Other pertinent labs include elevated ferritin, mild anemia, and transaminitis. An ultrasound of the abdomen was performed and notable for mild splenomegaly. The peripheral blood smear showed no evidence of hemophagocytosis, but the team is concerned for HLH, so they went ahead and sent the IL-2 receptor test, or soluble CD25. So this took some time to come back, but it did come back elevated. But in the meantime, she rapidly decompensated with multi-organ failure and pancytopenia. She is now in DIC and requiring cryoprecipitate. How should we proceed? So A, she does not have HLH since there was no hemophagocytosis on the smear. B, start treatment following HLH 94. C, use the HLH 2004 protocol. D, she's too unstable to proceed with treatment, wait until clinical status improves. Or E, treat her infection and then proceed with HLH treatment. Yeah, so still doesn't seem to be working. We're 0 for 4. So we'll raise our hands just to go through them. So who thinks A? Good. Who thinks B? That's not wrong. C? Yeah. D and E. So I think actually either B or C would have been appropriate. B has published data. C does not. But like I said, we know that B hasn't been sufficient in the past, so using the 2004 protocol I think is what we would try to do here, as long as she could tolerate the cyclosporin up front. So just a little bit of information. This patient actually responded up front, and then her peripheral T cell did not respond well. She was refractory, which caused her HLH to recur again. And so we actually ended up getting control of both of them and taking her to a transplant. She has since done very well. So for implementation at your institution, so based on the lack of consensus guidelines and limited data, 2004 protocol is encouraged, but 1994 protocol is okay to use as well. Find out what labs your center is able to check and how long they take to return. Clinical trial participation is encouraged, and then I also encourage you to utilize that monitoring chart, as I find it very helpful. There's currently limited options for salvage and refractory disease, so a lot of times you're choosing based on very patient-specific characteristics. Do not wait to escalate therapy or move to salvage, and then continue to watch for those HLH 2004 results which are pending. And then just for your own knowledge, since we recently had a patient, there are case reviews and reports of HLH in pregnancy, so those are out there if you have one of those patients. And then we'll gladly take any questions.